Hey, there we are. Awesome. Okay, so here are the objectives for tonight's webinar. Okay, as always, going to just generally be talking about these two types of conditions, just refreshing you guys' skills, tell you some important things you need to know as far as NCLEX testing. And then we do our 10 questions NCLEX review to see what you guys remember or what you retained. So first up, we are starting with mood disorder. So first up, bipolar disorder. So, main question, what is bipolar disorder? So, this is a mental health condition that causes shifts. Okay. And when we say shift, you mean a change. And it's an unusual change. So it's not like, someone made you upset and then you got mad. See, that makes sense. Or something happened that made you sad, you're crying or you're upset. Those are typical shifts. It makes sense that you are experiencing those emotions because of something that happened. But when it comes to bipolar disorder, the shifts are unusual. They're unfounded. There's no, precepting reason why the client has shifted into this mood. Most times there's no cause. The client just goes up and down shifting. The mood, the energy, activity levels, your ability to do your ADLs, all of those things shifts up and down, okay, throughout the day. You can also call bipolar disorder manic depressive disorder. I'm pretty sure you guys are familiar with that term as well. And when it comes to the shifts in moods, it's dramatic. Okay. It's like when you're high, you're high. And when you're low, you're very, very low. And the shifts can come at any time without warning. So that's a general overview of what bipolar disorder is. Now, there are two types of bipolar disorder, which a lot of people probably do not know, and there are distinctive characteristics of both. So, when it comes to diagnosing bipolar disorder, a person is generally categorized as either type 1 or type 2 based on symptoms that a mental health provider clarifies. So, first, with type 1, it is categorized by mania. So, when you hear the term manic, okay, that is more or less describing type 1. So these clients, if they have type 1 bipolar disorders, their mood shifts really, really high into manic signs and symptoms. Okay, and we will talk about what those are also. These clients may have a depressed episodes, meaning they may see shifts low in their energy where they almost appear depressed, the typical symptoms that you see with depression. However, they do not have to have experienced those depressive symptoms in order to get a diagnosis of bipolar disorder type 1. So that's important to know. Okay. They can definitely have the manic episodes, but they don't necessarily have to have the depressive mood changes to get a diagnosis of type 1. This disorder can also be associated with other psychotic conditions, delusions, and hallucinations. So, and it kind of makes sense that in a manic state, the client may start experiencing hallucinations and delusions. So, for example, a hallucination would be something that you think you see or hear, but you actually don't. Okay. Or someone else cannot hear, they'll see what you are hearing and seeing. So you can have visual hallucinations or auditory hallucinations. Okay. And then when it comes to the delusions, it's usually just the reality for the client is not 100% there. Okay. They can have delusions about things that they think is going on. They can have delusions about their own thoughts. And, it's really important to try to reground the client when they're having those shifts in moods. And we say reground, you don't want to make the client feel like something is wrong with them, but you also want to deal with reality. So when you respond, when you care for them, anything that we do for these clients is centered around bringing them back to as functional of a state as possible. And that also includes therapeutic communication. With bipolar disorder type 1, electroconvulsive therapy is typically utilized in cases that do not respond well to conventional treatment. We will actually talk about ECT later in the presentation when we go through depression, because this type of therapy is also utilized in depression. When it comes to treatment, now remember, treatment is not one size fit all, especially when it comes to mental health disorders. We treat clients based on their needs at that present time and also long term. So when we do those treatments, we expect to see, of course, improvement in symptoms. And if we don't see improvement in symptoms, and mind you, doctors will try different things, then they will resort to electroconvulsive therapy. Okay. And this uses electricity or electric currents to try to improve the client's mood. So we'll go into more details through the depression presentation. Now, bipolar disorder type 2. So this is characterized more by hypomania. Okay. So there is a little bit of manic behaviors there, but there's not as present, or they're not as prominent as a client with type 1 bipolar disorder. So the client can have highs, but they're not, extremely elevated in terms of the type 1 mania that you would see. These clients have had at least one major depressive order sometime in the past. And this is important because in order to be diagnosed with type 2, you have to have had a major depressive disorder episode at least once. With type 1, it is not necessary to have that type of disorder. Okay. Typically, type 2 is not associated with any other type of psychotic signs and symptoms, such as hallucinations and or delusions. So that's also important to distinguish type 1 and type 2. And lastly, therapy is typically effective as long as the client remains compliant. So with type 1, there may be a chance that therapy is not working, the medications is not working, or the client is not showing signs of improvement. However, with type 2 bipolar disorder, as long as the client is compliant, and compliant means they are following their plan of cares, especially when it comes to medication, then there's a good chance that the plan of care is effective and there's no other options that you would need to turn to. So make sure you know your differences between type 1 bipolar disorder and type 2. Okay. Usually, when it comes to NCLEX questions with certain mental health disorders, they do center a lot around signs and symptoms. Okay. Because with mental health disorders, making a diagnosis sometimes depends on ruling out other things. So, you don't always come directly to a diagnosis with a mental health disorder. So, if you're able to recognize clinical signs and symptoms, then you have a good chance of, determining what you feel the client is experiencing. Because they do ask questions like that. Based on these signs and symptoms, the nurse suspects the client is experiencing XYZ. Okay. And also, it's important to know your manifestations because that also helps when you are answering prioritization questions. A lot of times, mental health questions are steered around priority. What should I do first for this client that's experiencing this mental health condition? Okay. So now let's talk about signs and symptoms of, oh, got a question. Let me see. Oh, okay. So now let's talk about signs and symptoms when it comes to bipolar disorder. Now, remember, you can have manic episodes where the, client's mood is extremely, extremely elevated, or you can have depressive moods where the client's mood is, very subdued, almost mimicking depression. Okay. And of course, which one has what signs and symptoms. The manic episodes are more type 1 bipolar disorder, and the hypomania or the depressive symptoms are more or less seen in type 2. So with type 1, feelings of overly being happy for a long period of time. Now, you might say to yourself, what's wrong with being happy? But it's almost like the feeling is out of place. It's nothing wrong with being a joyful person. It's nothing wrong with being a happy person. The world would probably be a better place if we was all more happy. But with this type of happy, it's out of place. Like you're overly cheerful. If you ever notice first thing in the morning, you wake up, everybody not a morning person. I'm certainly not a morning person. So when I wake up in the morning, I'm struggling a little bit, right? But then you have somebody that comes in and they're just super, super, super overly cheerful. And you might say to yourself, why are you so happy? It's too early. Stuff like that. Now, I'm not saying that person has bipolar disorder. I'm just giving an example. It's just the feeling is just out of place. It just doesn't kind of seem right that the person has this emotion at that time. Talking very fast with racing thoughts. Now, this is interesting because when it comes to questions about how do I know a client is starting to experience a manic episode, okay, that typically starts with the speed talking and the racing thoughts. And when you say racing thoughts, their thoughts are kind of all over the place. They may not even be in logical, seasoning. It's just they're thinking about a million things at one time and they're expressing them. So it's kind of hard to follow them in conversation because they're kind of jumping all over the place. So that is usually one of the earlier signs that a client is going into a manic stage. Okay. They are easily distracted. Now, usually when we think of not being able to focus or easily distracted, it could be a stress response, or somebody might think it's ADD or ADHD, okay? Because that's also clinical for that condition as well. However, remember, it is also paired with the manic episodes, okay? Having overconfidence in abilities. Now, this is another one that people might think, what is wrong with that? It's nothing wrong with being confident in yourself. It's nothing wrong with, thinking that, I can do anything that I set my mind to. That is awesome attitude to have. But with this type of attitude, it's sometimes a task that might be very difficult to, complete. It might be something that might take an extended period of time to take, to finish or do correctly. But the person feels like they can do it in half the time or a third of the time. Oh, I'm confident I can get this done. Okay. And that's the manic stage talking because they're so full of energy. They want to go, 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 go. So they may feel that they can do something, that might take time and patience. They feel like they can do that quickly. Okay. And then lastly, engaging in risky behavior. A lot of time when people are in a manic state, they're fearless. That's a good way to put it. They are fearless, they risk, they want to take chances, they want to do risky things, and they might actually do a group of risky things. Now you have some people, adrenaline seekers. That's what we call them. They like to do stuff that normal people like myself would be like, I'm not doing that. Like, I'm not doing that. But for these people, they're adrenaline junkies. They like adventure. They like excitement. That's not what this is. These individuals is kind of like a rapid succession of just doing things, such as gambling. Okay. People get a rush when they gamble. And that's why gambling can become so addictive because when you win, it's almost like a euphoria that you feel. So this individual might engage in gambling behavior that is considered risky. Now, if you go to gamble and have fun, you might take a couple of little bit of money with you. You're not betting, your mortgage or nothing like that. You're being responsible. These individuals, total risk taking behavior. They might take all of the money that they have to pay for bills or something and they put it on gambling. And then, they possibly could lose because again, their thoughts are racing. So it's not like they're making logical decisions. They're just enjoying a rush and just, making irrational, quick decisions. Okay. Then on the flip side, you have your signs of the low of bipolar disorder or the depression type symptoms, feeling sad or hopeless for an extended period of time. Now, sometimes you might go through a period where, a lot is not going good and you kind of questioning, why is this happening to me? You feel a type of way. And again, that's a normal response, a normal emotion. It's usually tied into a stimulus. Something is causing you to have those symptoms, and whatever that something is valid, is real. With these individuals, however, with bipolar disorder, they are just feeling sad and hopeless, and there's no explanation. If you ask them what's wrong, if you ask them what's happened, they may not be able to give you a valid reason or a cause. It's just a continuous feeling of just hopelessness and sadness, and it just extends for a period of time. Okay. Significant change in appetite. A lot of times when individuals are going through that depressive state, they don't have an appetite and it may be marked by significant weight loss, which is definitely something to pay attention to. If you are a nurse caring for a client with bipolar disorder, you want to pay attention to rapid weight changes, specifically weight loss. Because again, when a client is in that suppressed state, their appetite is decreased. Oh, we have a question. Let me see. Thank you so much. Ah, you're welcome. You're welcome. Mental health is just a lot of observation. A lot of times treatments are similar. You just need to know what is it I'm looking for and what is priority. Okay. Um, Also, again, they may have a risk for dehydration. So that's another NCLEX spot that you might want to think about. If a person has a decrease in appetite, meaning they're not consuming, then they may also not be drinking fluids as well. Okay, that can lead to dehydration. Yeah, congratulations. I didn't even catch that part. Pass my NCLEX in 85 questions. Congratulations. Okay, RN, congratulations. Awesome. Love that. Because I see somebody saying congratulations. I'm like, what happened? I totally missed that part. Congrats. Congrats. Question. You guys can type into the chat or you can unmute and answer. If I was the nurse taking care of a client that was not consuming, let's say, a lot of fluids, okay, and they become dehydrated, what is a concern for me to have about my client and the fact that they are dehydrated? What can that lead to that I need to keep an eye out on? What you guys think? If I have a client that is dehydrated, what complication could that lead to? What do I need to watch out for? Electrolyte imbalances, exactly right on the money. So when it comes to the NCLEX, you have to think like that. If I have a client that's not eating, that's not drinking adequately, okay, especially water, exactly, especially potassium, they have a risk for becoming electrolyte imbalanced. And when you start thinking about what does that look like, hyponatremia, what is hyponatremia? Which one is that? Sodium. And then hypokalemia is, which one is that?
Potassium.
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 Perfect. So when it comes to hyponatremia and hypokalemia, you have to think, what manifestations would I see to if my client was in that state? Okay. Typically with hyponatremia, you see a lot of neurological disturbances, confusion, things like that. With hypokalemia, the potassium, first thing you might notice is cardiac arrhythmias. Okay, so it's very important to monitor your client's behavior, especially if they are not consuming a lot of food or fluids. Feeling fatigue or lack of energy. Now, this just goes beyond that I'm tired. I worked nurses, future nurses, working a 12-hour shift, back to back to back. You're tired. Okay, especially if you take on an extra day, because there's always a need for an extra nurse somewhere in the hospital, being that it's a shortage. So you probably work 3, 4, 5, which is not good, but 12-hour shifts. So you are just tired. You don't have no energy, you drained, normal and expected. These clients, however, the fatigue and the tiredness that they're experiencing, again, is really not an explanation for that. It's just a general feeling of just not having any energy to do anything. And that is important, especially when the client has depression, and we'll talk about why that is important as well. And then lastly, problems with memory and concentration. Okay. As you get older, or if you have a lot of things going on, you're stressed out, you may have a little bit of, confusion and a little bit of memory loss. You got a lot of stuff going on. So you can't remember everything. You can't think about everything. But with these clients, the memory loss and the confusion, again, what is it tied into? What is going on that your memory is so poor, or what is going on that your concentration is so poor? You have a lack of focus, or you try to focus and you just can't, and you don't understand why. Okay, so those are your symptoms between your manic episodes and your depressive episodes when you see your bipolar clients. So there is another type of bipolar disorder, and it is called cyclothymic disorder. Okay, and this type of bipolar disorder is a very mild form of bipolar disorder, but it is still a category by itself. Typically, with this disorder, you're going to have your mild symptoms of depression. Okay, and it has lasted for about 2 years or so. Now, what is interesting about this condition is, even though it is similar to mild depression, there's not a lot of symptoms, or there's not enough information for the mental health provider to make an actual diagnosis of bipolar disorder. So instead, this category of mental health disorder was created. Okay, so you have some of the symptoms, but you don't have enough, to make a definitive diagnosis. And a lot of these clients who have this disorder, they may not even recognize that they have this disorder. The symptoms are so mild. Usually with depression disorders, even if they are mild, or even bipolar disorders, even if they're, not the manic type, there's still something you can see, and there's still something you could put your finger on. Something is going on. With this disorder, again, the person may not even know they have mild depression or mild symptoms of bipolar disorder. So they may not even seek treatment. Okay. It's not like their daily life activities are affected. They're still going to work. They're still being functionable. But somewhere, somehow deep inside, there's a little something not quite right. Okay. This condition is slow and gradual. That's why, again, the symptoms could be missed. And a lot of times people don't even realize that, they have some type of a bipolar disorder until the symptoms become more pronounced. Okay. If these clients do not get treatment or if they're not recognize the symptoms quickly, they can definitely develop into bipolar type 1 or type 2 disorders. So in the beginning, they don't have the symptoms enough, or the mental health provider is not confident in making a diagnosis because they don't meet the criteria. But if they don't get the treatment, okay, or if they don't recognize that they are slowly, gradually developing bipolar disorder, then they can definitely, get to that point. So, signs and symptoms of cyclothymic disorders. Okay. Exaggerated feelings of happiness. So, again, you have your similar symptoms. Okay. Extreme optimism, inflated self esteem. Okay. So, those are like your grandiose thoughts. And if you guys know mental health, you know grandiosity is a mental health disorder. Okay. Inability to concentrate, easily distracted, irritable, or agitated behavior. And then the low signs, feelings of sadness, hopelessness, just feeling empty, suicidal ideations. And again, we will go over that in depression because that is an important piece of information for nurses to talk about or think about when they're taking care of these clients. Sleep disturbances, and then, of course, changes in weight. Again, weight loss, significant weight loss is a red flag. Okay, again, if the client does not have an appetite or they are not consuming fluids, they can become dehydrated, leading into electrolyte imbalances. So, how do we diagnose mood disorders? It's not like there's a test, that you can give a person and measure and say, okay, you have this, not like, measuring hypertension or measuring something else that has a lab that I can physically look at and read. So, how would you diagnose a mood disorder? Okay, a lot of it is a physical exam. Remember, you have to sometimes rule other stuff out. Is it a possibility that this condition could be causing these symptoms? That is something that you want to make sure you answer so you can confidently or accurately make a mental health mood disorder diagnosis. So once we start ruling things out through blood work, scans, CT scans, MRIs, PET scans, all the scans, ultrasounds. Okay. Once we do all of those tests, we can start ruling other possible conditions out that could be causing symptoms that the client is experiencing. Then, of course, they're going to have a psychological evaluation. Okay. A mental health provider will question you. They will talk about, your thoughts. They will talk about behaviors. Part of the diagnosis is awareness on the behalf of the client. Okay. You have to be aware that your mood is fluctuating. So, big part of the diagnosis is, of course, the questionnaire, asking the client what do they think about certain things, especially suicidal ideations. You may even give the client some type of a questionnaire to answer. Those questions, how often do I feel sad? 0 for not often, and then 5 all the time. Those types of questionnaires. Mood charting. So this is a good way to help the client to keep track of moods that will help diagnose a type of mood disorder. Basically what you do, it could be a journal or it could be something that is given to them by the healthcare provider. And the client is expected, to try to keep track of when they are experiencing these fluctuations in moods and hopefully how long it lasts if they have the awareness. We know that these moods can vary different days, different times. Something could be a couple of hours to a couple of days. So if the client can at least be aware that they are experiencing these shifts, and it's also helpful if they can tell you, this is how long I was feeling like this, that helps with diagnosing bipolar mood disorders. Oh, let me see. So treating mood disorders. So first thing we try are conventional methods, lifestyle modifications. Okay. Sometimes you just need a good night's sleep. Okay. A lot of times when clients are in that manic stage, they have so much energy, they're not sleeping. It's been 3 days and you probably got 2, 3 hours of sleep, if that. So first thing we want to encourage sleep. The body needs to rest. Okay. And that rest period might help to kind of bring the mood down a little bit. If the client is using substances like drugs, alcohol, we want to encourage that to stop also. Certain drugs and alcohols are stimulants. Okay, so if you are already experiencing a manic episode and you're on top of that taking a stimulant, your energy level is probably going to be through the roof. Plus, it's not healthy for the body. Think about the heart. Okay. If you're already overly stimulated and then I'm taking, let's say, a drug like cocaine on top of that, I can really stress my heart out. And now I don't just have a mental health disorder, I now have a cardiovascular disorder as well. Or you can stress yourself out so much, you can have a cardiovascular accident, okay, a stroke, a TIA, or something like that. Encouraging healthy dietary choices. A lot of time when people are in a manic state, okay, they're on a go, 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 go. You can't make them sit down. So something like sitting down to enjoy a meal might be out of the question at that moment. So instead, you want to teach, if you are having this episode, you still need to consume food, but let's give something that is easy for the client to consume when they're experiencing that manic stage. For example, finger foods. Okay. Finger foods are healthy. We think about the unhealthy stuff, but you can have healthy finger foods. So if I have a client that is in a manic state and I'm trying to get them to slow down and eat something, instead of trying to force this client to sit at a table, pick up a spoon, pick up a fork, and sit still, let me put out some finger foods. Okay. Something nutritious, something caloric, something that kind of meets their protein, all of that good stuff in a finger food that they can easily pick up and eat while, they having that manic episode. Then you have your psychotherapy options. So psychotherapy is talk therapy. Okay. Getting the client to talk, getting the client to express themselves. Remember, that is a big part of diagnosing clients. What their input in, what do they recognize or acknowledge as far as their mental health. So cognitive behavior therapy. This is probably one of the most common behavior therapies or common therapies in general that you may see when it comes to treating mental health disorder. Pretty much a lot of mental health disorders have some form of cognitive therapy in there somewhere. So with cognitive behavior therapy, you're simply trying to get the client to change their outlook. The way that they think, the way that they view things, you're trying to change that. And you focus in more on the positive stuff. So if the client continuously have negative thoughts, it's, with the low part of the bipolar disorder, you want to try to change that. You want to try to change the outlook. Okay. And you put more emphasis on the good stuff. It's almost like you're reprogramming. Okay. If I put emphasis on the good things and if I do that consistently for the client, hopefully their cognitive patterns will start to change. Instead of, thinking of things negatively, they start to look at the positive. So it's going to be your job to also help the client. What is the positive? What do I have positive that's going on? And you can always find something. Sometimes clients aren't just aware of it. So you as the nurse, helpful for them to kind of, point that out to them, good things that are happening. Okay. And then brain stimulation therapy. Sometimes the brain just need a little boost. Okay, little boost, little jump start. And those are types of therapies that we typically use, if conventional treatment is not really working. And again, electrocardio conversion therapy, we will talk about that in depression. Then you have your medications, your typical hallmark classification of drugs used to manage mental health disorders. Antipsychotics. Okay. Now there's a lot of antipsychotics that we have, and you want to pick the one that is right for the client. Sometimes it's a trial and error, and it's not one size fit all. So what worked for one client might not work for the other client. And also you want to make sure clients understand they have to be compliant with medication orders. You have to take medication, especially antipsychotics and antidepressives, for an extended period of time for you to start feeling an effect. Okay. A lot of clients think, as soon as I start this medication, I want to feel better tomorrow. It is not going to happen that fast. As a matter of fact, you guys tell me, what is about the average time that it might take for a client to start feeling the effect of certain antipsychotic medications? And this is important for teaching. So if you see NCLEX questions about education, when does these medications take time,
Up to
go
six
into effect?
weeks.
It's 4 to 6 weeks. Some take even longer. Okay. So that's a long time. So if you have a client that has yes, 2 to 4 weeks, 6 to 4 weeks, 4 to 6 weeks, I'm sorry, 6 to 8, 4 to 6, 2 to 4, depending on the medication, absolutely. So if you have a client that has an unrealistic expectation of their treatment, okay, and it's another thing, you do not stop abruptly. So if you have a client that has an unrealistic, expectation of treatment, they will not be successful because here they are 1 week later. I still feel the same way I felt a week ago. What is the purpose of me taking this medication, or this is not working? So when you see NCLEX questions about education, okay, what do I need to make sure that I include in my education to my client? When it comes to certain mental health medications, you need to take them compliantly. You need to be compliant because it can take an extended time for you to start feeling the effects. Do not be discouraged if it has been 2 weeks and you still feel the same way. Do not be discouraged if it's been 3 weeks, 4 weeks. It could take 6 to 8 weeks, 4 to 6 weeks. Okay. So that is important for you to let your client know so that they can remain compliant. Certain antipsychotics are very toxic. Lithium, for example, a highly toxic antipsychotic. And lithium is one of those medications where, even though it is effective, it can definitely cause a lot of side effects and adverse effects. So, clients need to also be taught you're going to have to come in regularly and have your blood work drawn so we can look at the therapeutic levels of lithium. Now, when it comes to certain dosages of medications, we need to make sure that the client is experiencing a therapeutic level of the medication. You do not want to give clients more medication than they necessarily need to have a relief of symptoms because, again, lithium is toxic. Okay, it's like digoxin, which is a medication for heart issues. You want to make sure that you are maintaining a therapeutic level. So, based on those labs, okay, the doctor may either decrease dosages or increase dosages. Question: what is the name of the test that I would draw, or the category of test, if I wanted to know how much therapeutic levels of medication? Like if I wanted to know, how long does the medication last in the body before it starts to, be eliminated, the time that this medication is most effective, what type of lab is that? Anybody. It's you would tell the client you got to come in when they're taking lithium. You got to come in, you got to have this lab drawn. Trough, peak and trough. Exactly. Look at y'all. Peak and trough. Okay? And that is important for clients to know. Okay? I can't put you on a medication like this and you just go off into the wild. You'll never come back. You got to come in regularly so we can draw your labs to check the peaks and the trough. Okay? Oh, think I had a question. Let me see. Yes, peak and trough. Perfect. And then, of course, your anti-anxiety medications. Again, mood disorders, mood stabilizers. Sometimes there's a aspect of anxiety with the mood disorders. So hopefully, if we manage the anxiety, we can also manage the mood. So, nursing management for clients with a mood disorder. And of course, this is your NCLEX stuff. First, you want to make sure you keep the client in a safe and therapeutic environment, especially when they're in a manic state. Okay. When a client is in a manic state, they can injure themselves, they can injure others. Okay. Especially if they're having hallucinations or delusions. Okay, hallucinations, delusions, somebody trying to get me, somebody trying to hurt me. So they're hyper vigilant. Okay, you just being a nurse, coming into the room to give them a medication, and they suspect that you're there to harm them, and then they attack you. Okay, so you want to keep the client in a safe therapeutic environment, not just to protect themselves, but to protect others. Okay. Encourage compliance with care plans. Again, this always stems back to especially medication. Okay. Make sure you stay compliant with medication orders. Again, you're not going to immediately feel the effect, but if you stay compliant, eventually within a couple of weeks, you will start to notice the effects. Okay. It's also important to attend therapy sessions if that's what's ordered. Again, part of treatment is getting client to acknowledge and recognize these feelings so they can work towards resolving them. Monitor mood and behavior changes. This will help you to determine what state my client is in, because depending on the state that they are in, the needs will change. Okay. If I have a client in a manic state, Okay, I might need to try to encourage sleep some type of way. If I have a client in a depressed state, they might be sleeping too much. Okay, overly sleeping. So that means I got to get them up, I got to get them moving, I got to get them active. Assess suicidal risk. Okay, that seems to be a common denominator in a lot of mental health disorders when it comes to treatment, um, especially in depression. There's always a risk for suicidal ideations, and as the nurse, you need to assess your client's suicidal ideation, especially those that are depressed. Okay, redirect thoughts and excessive energy. Again, cognitive behavior therapy, giving a client something to do, something to focus on, something to get all of that energy out. You know, I don't want the client just, running around, even though fixed daily routine, exactly, even though it might help to tire them out, you know, you don't want them just running around, having a manic episode. Redirect, exactly. Reorientate. That's a big one. Okay. Reorientate, make sure the client knows where they are, especially if they having the hallucinations and the delusions. Reorient them, get them on a fixed daily schedule, a routine. For a lot of clients, especially pediatric clients, routine schedule is very, very, very important when you're trying to manage certain symptoms. Okay. And remember, they may have trouble focusing, so that might give them a focal point. Any questions with our mood disorder? So remember, you have bipolar type 1, bipolar type 2, and then your systemic depressive disorder or mood disorder. Any questions with those three? Check the chat to see. Okay, so let's see what time it is. Okay, it's about 9:50. We're making good time. So let's come back at 10 o'clock and we will go through depression and then we will go through our NCLEX questions. Okay, so for everybody, it is about 9:50. We will start back with depression at 10 o'clock p.m. Okay, students, welcome back. We are now going to discuss depressive disorders. Okay, hopefully everybody is back, ready to go. Okay, so depressive disorders. So what exactly is depression? Okay. So depression is a mental health disorder that addresses mood changes, typically depressed mood changes, loss in interest, pleasure, things that you used to like to do. You don't have an interest in them anymore. It's not just, you change hobbies. You used to like, to draw, and now all of a sudden you don't like to do it anymore. Okay. You may have feelings of self-worth, low self-worth, guilt for whatever reason. Sleep patterns are disturbed, eating patterns are disturbed, energy levels are disturbed, and you even have issues with concentrating. So it's a group of disorders, okay? It is not one size fit all, meaning depression may manifest differently in people. So it's important to be able to recognize general signs and symptoms so that if you do see it in a client, you can definitely help the client with making a diagnosis when it comes to the care that they will need. So your types of depression, there are typically three types. There are more, but these are the general overtypes when it comes to depression. You have mild depression, considered low grade. Okay. Symptoms are definitely not prominent. Even with this type of depression, the client may not recognize they have it. Um, it would take awareness that, you know what, I don't feel like my normal self. Okay. I don't know what it is, but it's something. For the client to be able to recognize that they are experiencing mild depression, it does take an awareness, because if you don't recognize it, other people might not recognize it. Because again, you just seem like, a typical person, or you could say, you know what, I've been working a lot more, so I'm not really sleeping too much. Okay. And that is a way to kind of explain why I'm feeling the way that I'm feeling. Moderate types of depression symptoms are more prominent. They're not severe, but they're definitely more prominent than the mild types. May start to see more signs and symptoms like actual sleep disturbances or headaches, the stress response, headache, fatigue, okay, pain. Those types of symptoms are now going to be shown because you're moving out of the mild category. And then you have your major depressive types. This is now clinical depression. This is the type of depression where it's treated, therapies, medications, the whole nine, because you fit the criteria clinically. Okay. Definitive emotional issues, and then it also starts to manifest as a lot of physical issues, and the physical issues may not have a cause for why you're feeling the way you're feeling. So these are things, again, pain, um, sickness. Sometimes people may feel ill, nausea, vomiting, the sleep pattern disturbances, the whole nine. Okay. Activities of daily living are officially affected with major depression disorder. With the other types, you may still be functionable. You still go to work, you still come home, take care of a household, you got kids, take care of the kids, you're still able to do that. With major depression disorder, your activities of daily living is affected. You have no interest taking care of yourself, taking care of others. You kind of let yourself go because you don't have the energy or the interest of doing so. Okay. So how do we diagnose depression, which is always a big question. You need to have certain criteria in order for a definitive diagnosis to be made. Okay. Symptoms must last at least 2 weeks or longer. Okay. And the symptoms that you have, again, they must be together and lasting for at least 2 weeks. So the headaches, the feelings of fatigue, the sleep disturbances, the nausea and vomiting, the feelings of worthlessness, the sadness, all of that comes with the depressive moods needs to be in existence for at least 2 weeks. Okay. They will do some labs and, exams to make sure there's nothing else causing you to have this disorder. For example, there is something called chronic fatigue disorder. A lot of times, it's hard to diagnose because it's not like it's something I can put my finger on. But if I have a client that's always tired or they don't have a lot of energy, they may not necessarily be depressed. They could simply have chronic fatigue syndrome. So they're going to, of course, try to rule out other things and then make a definitive diagnosis of depression. Screening tests. There are screening tests for depression. It's more or less questionnaires, getting the client to have an awareness of the signs and symptoms that they are exhibiting. You may even ask family and friends. Now, of course, you would need the client's permission to do so, but you can bring in, a close family member, a close friend who knows the client very well, and the mental health provider can ask them some questions. Is this typical behavior of the client? When did you start noticing the client was exhibiting these symptoms and things like that? And then lastly, the diagnosis needs to be made by a mental health professional. It cannot be any type of a medical doctor. It has to be someone that specializes in not only recognizing symptoms, but treating them as well. So speaking of, how would we treat depression? So there's a multi-focal point when it comes to approaching how to manage depression. Remember, it is not one size fit all. Some clients, they may need alternate types of therapy. Sometimes it's trial and error. Okay. With medications, of course, we know we start with our antidepressants. And something somebody said in the chat earlier was something that I wanted to stress. You have to teach clients when it comes to medications, they cannot stop them abruptly. Okay. And someone did put that in the chat, and I'm glad you said that. You cannot stop these medications abruptly. Again, that is why we stress the importance of staying compliant. Again, not just because you're not going to see signs and symptoms, your symptoms improving right away, but because you can't stop this medication abruptly. Okay. You will have side effects if you stop medications abruptly. Okay. Psychotherapy, again, cognitive behavior therapy, talk therapy, sometimes hypnosis, a lot of different types of psychotherapy to kind of help clients with managing symptoms. Lifestyle changes, regular exercise, a healthy diet, getting the client to go out once a week. We try to make plans social, unless the client has some type of social anxiety and the approach with being social kind of is different. You want to encourage the client to get out. Okay. Sometimes with the depressive state, they stay in the house, they don't go anywhere. Okay. They're in the house 24/7, they don't go outside. And you can set baby steps. You know, Today you're going to go outside, you're going to check the mail. Okay. Or today you're going to go sit outside for an hour. Okay. Or you're going to go to a place that has a lot of people, or if not a lot of people, just people in general, a park, somewhere where there's people present and you have to be around those people. You just go to a restaurant and grab something quick bite to eat, just trying to get the client out. Okay. Making sure that you promote good sleep patterns. Again, someone that is depressed definitely will probably oversleep, a lot of fatigue, a lot of tiredness, a lot of sleeping. As the nurse, you're going to have to try to, help them with that, because not getting enough sleep is not good, but oversleeping is not good as well. Self-help strategy. So when it comes to managing depression, what type of self-help strategies do your client have? What type of coping skills do your client have? When they're feeling a certain type of way, do they deep breathe? Do they listen to music? Do they go to sleep and take a nap? How does your client handle their depressive moods, or, the signs and symptoms that they're feeling? Sometimes we need to teach clients effective coping skills. They don't have it. What if they don't have a good support system? And having a good support system is a way to effectively cope. Do you have somebody that you can talk to or go to when you're feeling a certain type of way? Because support is also big when it comes to managing certain mental health disorders. Okay. Now we get into electroconvulsive therapy, also known as ECT. Now, this type of therapy is indicated if the typical methods for managing depression is not effective. So the psychotherapy, the medications, lifestyle modifications, if all of those are not successful, the client is still having the symptoms, or the symptoms have gotten worse, then you can go to the option of electroconvulsive therapy. Okay. Now, of course, you need to explain the therapy to the client. There will need to be an informed consent. You, as the nurse, would be able to witness the informed consent. Make sure that the client understands what the therapy is, that they understand the risk factors, because there are risk factors, and that they understand what the purpose of them having this therapy. Again, the other medications and the other therapy and all that other stuff did not work. Um, you were compliant, you were taking the medications as ordered. We just didn't see an improvement in mood or depression after all that time. Okay. So the basis of ECT is to use electrical currents to relieve symptoms of depression. So electrical currents, electricity. Okay. What happens is the client will have like probes. Okay. And you can set them on the side. And I know you guys have probably seen this in the movies. They have they look like little handheld devices. And, you can put them on the side of the head here. You might put one on the top of the head, but it goes around the head. Okay. And it's going to send electrical waves through the brain. The purpose of these electrical waves is you want to induce a seizure in your client. It is the goal to induce a seizure. That is why you may notice they put something in the client's mouth. So sometimes they might clench their teeth. Okay. And if they clench the teeth too hard, they can break teeth. Okay, so sometimes with electroconvulsive therapy, they kind of put like the little, like the mouth protector so when they bite down or they don't bite off their tongue, because that can happen also when they clench. So the goal is to induce a seizure. Okay, when the seizure is induced, there's going to be like a chemical reaction within the brain. The goal or the hope is that when that chemical change happens, it will improve the client's mood or it will alleviate the symptoms of depression. Okay, so that is the purpose of ECT. Now, part of the education beforehand is you want to make sure the clients understand there can be periods of short-term memory loss, short-term confusion, long-term memory loss, and long-term confusion. Yes, that's exactly it. The volts, and of course, they can always go up on the voltage also. Again, clients need to be made aware they can experience short-term memory loss and confusion. Okay. This can happen, and it does by age. Exactly. And that's another thing. Thank you for saying that. With the ECT, we do not use the same voltage on all clients. Depending on the client's age, we also consider current health state. That is going to determine how much electricity we will utilize with the current. Okay. Again, make sure clients understand they could experience mental confusion and short-term memory loss. These conditions can also last for an extended period of time. So, yes, there is a possibility that you can have long-term confusion and long-term memory loss. ECT is not 100% guaranteed effective. There are complications, there are risks, which is why the informed consent needs to be signed. The client needs to be made aware after the therapy. You may have some memory loss. You may have some confusion. It may last a short time. It can last for an extended time. This definitely happens in older people. Okay, so if you have an older client and the consideration is ECT, you definitely have to keep in mind they are already on the older side, and there's already, as health declines, periods of confusion or memory loss, especially things like dementia and stuff like that. So we want to make sure that this therapy is not going to potentiate the client's conditions that they already have and make it worse. Okay. So, nursing management of depression. Now, this is important and this is definitely NCLEX material. Okay. Always you want to promote a safe environment for the client. Okay. When a client is depressed, there is a concern, and the concern is suicidal ideations. Okay. A lot of clients with major depressive disorder, they have considered suicide at some point. And this is just known through the questionnaire, simply asking, have you had thoughts of hurting yourself? And a lot of them will say they have. The issue is they may not have the energy to carry out a suicidal plan. You know, they might have it planned out. They might have, know exactly what they want to do. They want to know how they're going to do it, where they're going to do it. A lot of people have that detailed, but the energy to complete the plan is not there. So while it exists in theory, they don't have the energy, they don't have the stamina to actually go through with the plan. Once they start getting treatment and once they start feeling better, okay, and this is definitely NCLEX material. Once your depressive client starts feeling better or their fatigue starts to letting up, you need to be more vigilant in terms of your assessment. Now the client has the energy. Now the client has the means to carry out suicidal ideations. So while it's a great thing that the client is feeling better, their mood is improving, that's what we want. We also know with this mood change or this mood improvement comes the risk that they will carry out a suicidal ideation plan. So that's NCLEX. Okay. What is an important priority to monitor or assess in depressive clients? Suicidal ideations or suicidal thoughts. Okay. Coping abilities. How do you manage stress? When you feel down or when you have these feelings, what do you do to try to cheer yourself up? What do you do to work your way through these feelings? Okay. Promoting health and wellness, exercise, good diet. Sometimes diet is a reason why you don't feel well. You eat a lot of junk, or you eat a lot of sweets, or, you binge eat, or whatever the case may be. You want to promote health and wellness. A walk might make you feel better. Get out, breathe some fresh air, go out with a friend if you don't want to go out by yourself, promoting health and wellness and exercise. Definitely something that can help with managing depression. Encourage the client to verbalize feelings, thinkings, worries, etc. It's important to get the client to be engaging in terms of therapy, psychotherapy. Okay. Remember, a big part of making a diagnosis is the client's input, their ability to be aware that they even have these symptoms and to recognize this is not normal. Okay. Therapeutic distances, exhibiting open posture. So you want to maintain boundaries with clients. Anytime a client has a mental health disorder, you definitely want to establish boundaries. Okay. You do establish relationships with the clients, rapport. You are the nurse. They are your client. You do form a relationship, a bond, but you need to make sure it stays professional. A lot of times with mental health disorders, clients will try to push the limit. They may try to manipulate, they might try to put one against the other, passive aggressive. You may typically see that. Okay. So it's important that you maintain professional boundaries. Okay. Because also you don't want to confuse the client also. Okay. And then lastly, do not hurry the client when you are interacting with them. Give them time to complete thoughts. Give them time to complete an activity. That is why when clients are in a depressive state, remember, they don't have the energy and the stamina like a client who has bipolar type 1. Okay. This is the low of the low. So you want to be patient. You want to make sure you give the client time to, get their thoughts together. And that's also a sign of respect. When you have a client that has a mental health condition, any type of a neurocognitive condition, and they're not functioning, at the alert speed that you might be used to, you have to have sympathy, you have to have empathy, respect, dignity, because even though these clients have these conditions, they still deserve the right to be autonomous. They still reserve the right to make, decisions regarding their medical care. Any questions with depression? That was a quick one, but depression is pretty simple concept to understand as long as you know what your symptoms are. And of course, watching out for suicidal ideations, the plans to actually carry the plan out. Okay, so let's see what time it is. Okay, you're making good time. Good, good, good. So it's 10:20. I'll give you another quick little breather. And then at 10:30, we will start with our NCLEX questions. Okay. So 10:30, you guys, we come back, we'll go through the questions, and then we'll be done for the evening. Hopefully everyone is back. Let's go through our NCLEX questions. So there are 10 questions, and each of these questions are about the concepts that we just talked about, mood disorders and depressive disorders. So you guys feel free to type into the chat your answers, or you can always unmute and, say your answers. You can always ask questions. Okay. Just want to make sure you guys understand the concepts. And again, if you have any questions, please feel free to ask. Okay, question number 1. A client diagnosed with bipolar disorders asks the nurse why it is necessary to have a serum lithium level drawn every 3 to 4 months. The nurse's response should be based on which factor? A, to monitor compliance with the medication. B, to prevent toxicity related to the drug's therapeutic range. C, to monitor the client's white blood cell count. D, to assess for hepatotoxicity. So let me see what we
B.
got in the oh, let me see. Okay, look at y'all. B, 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 B. Of course, the answer is, oh, did I do that wrong? Put that wrong. My fault, you guys. The answer is B. I'm gonna fix that. The answer is B. You guys are correct. The answer is B. So, as we stated, it is important to do your peak and trough levels as well as your typical labs just to see if the client is experiencing lithium toxicity. This is a serious, potentially adverse side effect of lithium administration. Oh, somebody's putting a range. Okay, look at y'all. Listen, it is good to know your lab ranges. Okay. Oh, show the question again. Sure, sure, sure. So, yes, it is important to make sure the client understands that they have to have therapeutic labs drawn, however often the doctor wants them to do so. If we see that the client is displaying signs of toxicity, then of course the healthcare provider will alter the dose. We also want to make sure that the client knows that they cannot stop the medication abruptly as well. So you do see a lot of questions on the NCLEX regarding medication education. Okay, because a lot of treatment for mental health disorders do center around compliance. Well, you're probably welcome. Centers around compliance with the medication regime or just the plan of care in general. So I will fix that. The correct answer is B. You guys are correct. The rationale reflects the right answer. Just trying to figure out how. I know it's on the same row, but how did I put C if not B? Question number 2. A nurse is explaining electroconvulsive therapy to members of a depression support group. Which statement would indicate understanding? So these are your typical NCLEX questions where you perform some type of education and the client is going to make a statement. If teaching is effective, then the statement is accurate. Okay.
A.
Let
Yes,
me
I use A.
see. I see a lot of, I heard A. I see A's. Okay. Let's hope my fingers didn't press the wrong answer with this one. Treatments are given for severe depression when other meds have failed. Treatments are given as a one-time treatment to someone with depression. Treatments require shaving hair at the temples prior to treatment. Treatments are safe. There are no major side effects or complications. Yes, the correct answer is A. Okay. Again, when it comes to major depression, if conventional methods such as medications, therapy, lifestyle modifications, if those are not successful, then yes, there is an option for ECT. Okay. And again, it involves using electrical currents to induce a seizure. And hopefully, with the seizure, certain chemicals are released and it alters the brain function to improve depression symptoms. So, again, if you want to explain, you also include that as well. Okay. And there are side effects. I think it's in another question, so I won't talk about it just yet. The question number 3, the nurse teaches a client with bipolar disorder about lithium therapy, which client statement indicates the need for additional teaching. Okay. Now, this is a typical pharmacology question, and I purposely left this out to see what you guys remember about pharmacology. Okay. There are roughly about 300 medications that can randomly show up on an NCLEX. So you have to have a strong knowledge in pharmacology. Okay, so let's see. It's important to keep using a regular amount of salt in my diet. It's okay to double my next dose if lithium. If I forget a dose, I should drink about 8 to 10 cups of water each day. I need to take my medicine at the same time each day. And of course, the majority of answers are correct. B. Now, again, lithium has a high risk factor for toxicity. You definitely need to correct the client if they state, I need to double my dose if I skip. Absolutely not. You're already at risk for toxicity with one dose. Doubling is not going to help that any better. So instead, you teach the client just take it again at the next scheduled time. Okay. When you have medications that are highly toxic like that, it is important to stick to a plan. Do not double your dose. Take it around the same time every day. Clients should consume a regular amount of salt. Okay. Lithium can affect salt levels, which can affect electrolyte imbalances. They also should drink plenty of fluids each day while taking lithium. 8 to 10 cups of water is adequate. Okay. Again, clients may become thirsty, which is also affecting with the salt levels. So if they drink a lot of water throughout the day, that kind of helps with the decreased thirst or the increased risk for decreased thirst, as well as the risk for dehydration and electrolyte imbalances. Question number 4. The nurse teaches a client about bipolar disorder, which statement indicates that the client has developed insight about the diagnosis. A, I enjoy feeling high. I don't need much sleep then and get really creative. B, my medicine really helped me. I know I won't need it in about another week. C, I'm cured now. I was really wild for a while, even though I got into trouble. D, I know I'm getting sick when I don't need much sleep and start buying things. So insight means that you have an awareness or you have an understanding about something. So if I was educating a client about bipolar disorder, which statement indicates the client has developed awareness about their condition? I think somebody was trying to talk. Go ahead, say what you was about to say. If somebody was trying to talk. D, yes. See, majority is putting D, and the correct answer is yes, D. Okay. Teaching a client about bipolar disorder, one of the ways that we help is to make sure the client is aware of what that feels like. Okay. When you start experiencing this, that means this is happening. Okay. Buying things randomly could be impulse. Okay. And impulsiveness can be a component of manic behavior. When the client's not sleeping, okay, because of the manic behavior, that is typically a sign that that stage is starting. So if the client has awareness that they're starting to go into that stage, they can start the treatment or effective coping strategies early. Okay, good job. Question number 5. A client with major depression undergoes a 6th cardioconvulsive therapy treatment. When assessing the client immediately after ECT, the nurse expects to find what? So this is about the education that we need to make sure clients understand when they undergo ECT therapy. It's not always a one dose therapy. Some clients may need additional doses, but it all pretty much is the same thing, electrical currents. So A, short-term memory loss and permanent long-term memory loss. B, short-term memory loss and hypertension. C, long-term memory loss and hypomania. D, short and long-term memory loss and confusion. So what would I expect to find in my client after I see D's and I see a B? Interesting. So let's see what the correct answer is. Oh, got one more entry. Okay, so the correct answer is majority D, yes. Now, remember, this is why it's important to do an informed consent so the client is aware of the potential side effects. While ECT can be effective, it does come with a price for some clients. That is long-term and short-term memory loss and confusion. Now, is this going to be permanent? Okay, we can't say yes, we can't say no. Okay, every client is just more or less of a waiting game. Some of the things that you can do for the client, let's say you are a family member or the nurse, you can, reorientate them as much as possible. Show them pictures, have conversations to try to jog memory. But, again, that is a risk of ECT long-term, short-term memory loss, and confusion. You want to make sure you reorient them to the space that they're in, because that is also how you create a safe environment for the client, because confusion can lead to agitation. Okay, good job. Question number 6. In a pre-discharge program to educate clients with bipolar disorder and their family members, the nurse emphasizes that which symptom is the most significant indicator for the onset of a relapse. So again, that awareness that we want clients to have about their condition. A sense of pleasure and motivation for new endeavors. B, decreased need for sleep and racing thoughts. C, self-concern about an increase in energy. D, leaving a job to start a new business. So what would be an initial indicator that my manic is starting, is coming back? What would be an indicator for that? Let's see in the chat. Ooh, I see a mix. Oh, this is a good one. So I see a mix of answers. I see D, I see B, I see C. So nobody is saying A, which is good because A is not the correct answer. Okay, because you want to be happy when you're doing something new. Like if you're traveling to a new place, you happy, you excited. So A is not the answer. But I do see a mix. B's, I see majority B's. And I did see a C and I did see a D. Okay, let's see. The correct answer is B. Okay, the initial signs that you're going into a manic episode: decreased need for sleep and racing thoughts. Remember, this is a sign of the mania. Okay, the manic stage of this disorder is your thoughts all over the place. When you talk, you kind of, not making rational sense. Again, you're just all over the place. And remember, as you become more stimulated, less and less need for sleep, less appetite, and so forth. Okay, good job. Question number 7. A client is in the manic phase of bipolar disorder. To help the client maintain adequate nutrition, the nurse should plan to what? So we talked about this during the presentation. Remember, when they're in a manic phase, they on the go. Might not be able to sit still, might not be able to focus or concentrate. So go ahead.
Finger food.
So I see, good. Look at y'all. The correct answer is yes, finger foods. Okay. Listen, finger foods and sandwiches, they can be nutritious depending on what you give the client. And remember, because they have all that energy, they may not be able to sit down at a table with a fork, and that might not be the safe thing to do anyway. Give them a fork and a knife, utensils. Not saying that they can't use them, but in the manic phase, you still want to promote safety in a therapeutic environment. So while they're in that manic phase, just give them some finger food, something that they can easily pick up and eat. And again, nutritious. It has, the calories that they need, the protein. So you want to pick well-rounded finger foods. Okay. I'm going to go back so you can see some of the other answers. So large meals, they may not have the focus to eat a large meal. They want something quick. You got to give them something quick. So while you do have their attention, they can eat something. A stimulating mealtime environment, that is the opposite of what you want to do. You want to decrease stimulation. They're already in a manic stage. So adding a stimulus is going to make the behaviors probably worse. And then letting a client choose favorite foods. Now, some people might have thought that could have been an answer, and it's not bad in theory. However, the client might not be able to think, okay, I want this, I want this, I want this food. Because they're in a manic stage, remember, their thoughts are racing. So who knows what type of combination of foods they'll put together if you give them the option versus saying, this is your meal. Okay, and you need to eat. So you are establishing for the client, because again, when they're in that manic stage, their thoughts are all over the place and they might not have logical thinking. Question number 8. The nurse is conducting an in-service on cyclothymic disorder. What statement should the nurse include in teaching? So I'm educating clients on, or anyone, an in-service, other nurses, other healthcare providers. And what do I need to make sure that I say about this condition? Okay. These are questions that you're going to see on the NCLEX. If you plan to teach a topic, it is important that you say this. Okay. And I see a lot of B's. I see a D as well. Okay, so we have some different answers. A, it involves a single manic episode. B, symptoms are more prevalent in the fall or winter. C, it is similar to major depressive disorder, but there are no suicidal ideations. D, its symptoms are similar to bipolar disorder. The correct answer is yes, D. Okay, so if you remember, this is a condition of bipolar disorder. The issue is the symptoms are there, but the symptoms are not so prominent that the doctor can make a definitive bipolar disorder diagnosis. So you're kind of sort of like in limbo, okay? You're not mentally 100% well, but you're not, so bad or you're not so advanced with your symptoms that you have bipolar disorder. So instead, you're kind of in the middle. And again, these clients might not even recognize that they have these symptoms because their symptoms are not very prominent. Okay.
Yes.
And
Free.
yes, go ahead.
No, I just said symptomatic free. That's all.
Yes. Uh-huh. And also they have the hypomania. Okay. They have a little bit of increase in energy, but again, it is not the typical manic stuff that we expect to see. And they may have at least more than one episode of depression. Question number 9. The nurse is caring for a client with bipolar disorder who was recently admitted to an inpatient unit and is experiencing a manic episode. What is the priority nursing intervention for this client? So, priority questions. Sometimes students have trouble with these. Now, when you are picking a priority, you are not saying that the other options aren't good options or they're not something that you would do. You are simply establishing what is the very first thing that I should do before I do anything else. Okay. A, prescribe and administer all medications in liquid form. B, base permission for family visits on the client's attendance at therapy groups. C, closely monitor the client's eating and sleeping habits. D, encourage the client to keep a journal about feelings and emotions. So, priority, first thing. Go ahead.
That's it.
I see a lot of C's. Let's see. Of course, the correct answer is C. Okay. If the client is starting to, show those signs and symptoms, let's look at your sleep patterns. I'm gonna go back so you guys can see. Oh, I'll go back. So if the client is starting to go into a manic episode, again, one of the initial signs and symptoms are sleep disturbances, and of course, the eating habits kind of decline as well. Remember, it is a stimulating effect. Decrease in appetite, decrease need for sleep. They have a lot of energy, so they're go, 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 go. You want to see where they are in the process. Now, because the client was admitted, it's not like you saw them start to advance. So you really have no idea where they are in the manic episode, but you want to start with, have you been eating? Have you been drinking? How much sleep has you really gotten? You want to start there and then you go from that. Okay. And last but not least, question number 10. A client has been hospitalized for a major depression and suicidal ideation. Which statement indicates to the nurse that the client is improving? So this is a different type of question. Now, we said when you have a client taking antidepressants, you need to monitor for suicidal ideations because they now have the energy to carry out a plan. This kind of asks you, how do you know the client is improving? So it's not just that their depression mood is improving, but their overall thoughts are improving as well because suicidal ideations is not a good thing. Okay.
B.
B, I don't. So A, I couldn't kill myself because I'm afraid. B, I don't think about killing myself as much as I used to. C, I'm of no use to anyone anymore. And D, I know my kids don't need me anymore since they're grown. And I am looking at the chat. Of course, the
B.
correct answer is a B. So that's a good thing. Okay. Yes, they're feeling better. Yes, they're getting more energy, less fatigue. However, on top of that, they're not having the suicidations like they used to. They're not considering carrying out the plan because, again, that is a concern. Once they have the energy to do so, they carry out suicidal thoughts or ideations. So, yes, this is a sign that they are not just getting better, but they are improving in terms of thought processes, which is a big part of managing depression. Good job. Y'all did really, really, really good on this. Mental health is one of those things where, are there any other psychotic disorders that bipolar, you can use bipolar. If it's not managing bipolar correctly, you can use ECT, depression, any type of mental health disorder where you want to improve thought processes, okay, or improve symptoms, you're going to see the need for ECT possibly. Before you guys go, I am going to put a link into the chat. Those of you who've been with me before, or those of you who have attended webinars, you guys know how this goes. So I'm going to put a link into the chat. You guys, please feel free to click on that link, leave reviews, positive reinforcement, something you guys want to see more of, something you want me to do, please leave that in the chat. Can you explain question 4 again? You guys are welcome. You are welcomed. So I want to make sure I answer Shy. I hope I'm pronouncing it right. Question first. So, again, bipolar disorders, depressive disorders. You can even use it for the anxiety, panic attacks, anything where you're just trying to improve the chemical makeup in the brain. Okay. Now, this is not something that we easily go into doing because of the side effects or the lasting side effects. So you definitely want to make sure nothing else is working if you go that route. Okay. You're welcome, Victoria. So Joy wants me to go back over question number 4. Of course, Joy. I'll share my screen again also to go back to 4. Okay, let me share my screen. Oh, and for everyone else, if you guys are done and you have no additional questions, you are free to go. Please remember, click on the link, leave your review, and I will see you guys. I do hold another session on Wednesday. It's adult health. You guys can look in the schedule to see what that topic is. So, you guys, good night. Have a great night. Okay, let me make sure who I'm answering. Miss Joy. Let me share my screen so you can see question number 4. Okay, so you should be able to see it. You're welcome, Juliet. Have a great night. Let me go on the slideshow view so you can see it better. Okay, so question number 4. You're welcome. The nurse teaches a client about bipolar disorder, which statement indicates that the client has developed insight. So again, insight is a way of saying awareness. Okay. If you have insight to something, you have an awareness about it. You have an understanding of it. Okay. Insight also helps us to kind of self-evaluate, which is what this is about. If you have an understanding or if you have insight about the bipolar disorder, then you are able to recognize, okay, certain factors when it comes to the different, stages or phases that you can go through. So for question number 4, I enjoy feeling high. I don't need much sleep then and get really creative. That is not accurate. Okay. The feeling that is high is manic episode, and a manic episode can be dangerous. Again, not sleeping, not eating, impulsive. Okay. So while it may feel good because it does induce euphoria, which is a sense of feeling good, it is not safe to be in a manic stage. So the insight is not there. Okay. B, my medicine really helped me. I know I won't need it in about another week. Not accurate. Again, even if we take a client off a psychotic medication, they cannot stop it abruptly. Okay, session cleared effective. Really appreciate it. I can do 1 and 2. Yes, I can. You can wait after 4. I'll do that. So again, even if we do take a client off for whatever reason, you can't stop it abruptly. And stopping in a week is abrupt. Okay, some of our antipsychotic medications, they can cause type of withdrawals or rebound symptoms. So you definitely don't want to stop it in a week, even again, if that's in the agenda to take the client off the medication. See, I'm cured now. I was really wild for a while, even though I got into trouble. So it's not about curing. Okay. And I think that's the misconception with the insight. It's not that it is cured, your symptoms or your condition is well controlled. Okay, that's a difference. You cure a bacterial infection. I can cure that. I can take antibiotics and then my infection clears up. So that is when you cure. When it comes to mental health disorders, you're managing or you're controlling your symptoms effectively because honestly, it doesn't ever really go away. Okay, even if you improve, you're no longer depressed, you haven't had symptoms of depression in years. If you've experienced before, you can easily go back into that state again. I'll give you another example. Pregnant women. Okay, one of the things we have to assess in pregnant women, have you had any episodes of depression or have you ever suffered from depression? That is important to know because your risk for developing postpartum depression increases if you had depression in the past. So even though you feel better, you can still go into that stage easier. So you're not necessarily cured, you're just being well controlled with the symptoms. So the correct answer was D. I know I'm getting sick when I don't need much sleep and start buying things. So this statement indicates the client is aware. When I start having a manic episode, this is what can start to happen. I can start, I'm not eating as much. Or, I have a lot of energy. I'm more impulsive, which is the buying things. Okay. I don't need a lot of sleep. I'm not sleepy at all. I've been up for 3 days and I feel great. That's what we're talking about. We mean the manic beginning stages of that. No problem, Joy. So I had a student ask me for 1 and 2. So let me go back. You're welcome. You guys are welcome. So question number 1, a client diagnosed with bipolar disorder asks the nurse why it is necessary to have a serum lithium level drawn every 3 to 4 months. The nurse's response should be based on what factor? So again, this goes into the education when it comes to antipsychotic medications. Lithium is a very common medication that we prescribe as an antipsychotic. And while it is a common medication, it is also a very toxic medication, and a client can develop something called lithium toxicity. So, to make sure or reduce the risk of that happening, the client has to have regular labs drawn. Okay. Now, the healthcare provider will determine how often, but the client needs to be taught. You're going to have to come in periodically. Okay. Whatever the doctor says for us to do lab work, we have to see how much lithium remains in your blood because you can have a therapeutic effect, but it could be a toxic or toxicity to follow with that therapeutic effect. So if you have higher than abnormal levels of the blood of lithium in your blood, the doctor will probably lower that dosage. Or on the flip side, you've been taking lithium for a while now, but your symptoms are not improving. Maybe the doctor hasn't given you enough medication. Even though we know it's toxic, we still need it to be effective. So maybe your dose needs to be high, increased because you're not experiencing, any relief of symptoms and it's been so long. And we can also tell by doing your blood work because we get to see how much lithium is in your blood. So if you are taking it regularly like you're supposed to, that lab would also tell us that as well. Okay, so the nurse response to monitor to prevent toxicity related to the drug's therapeutic range. So that would be the correct answer. Okay, a lot of times clients will question you why you got to do this or why you need to do that. Okay, and honestly, if you educate the client, you're going to have probably a better chance of them being compliant. Okay. When people understand what's going on, when people understand their care, when people understand the need to do stuff, they're more likely to be compliant. And this is also true with children. If you are taking care of children, children can be difficult, especially in the hospital. They're scared. They don't want you to touch them. They don't want to do this. But if you explain to them or you give them a little bit of say so and stuff, you can increase compliance. Okay. So definitely want to make sure you educate the client. Access. So I'm not as sure how the access to the recordings are done. I know that the recording gets uploaded and the administrators of the site upload it somewhere. You can always contact support for that answer. Unfortunately, I'm sorry.
You go into previous webinar on the slide, you in your your account, you will see it there and you can just upload it from there.
There it is. Thank you. Well, listen, you learn something every day. Thank you. Now I know. So you go back into previous webinars and the recording is there.
Yeah.
Perfect. Now I know. Thank you so much. See, because on my end, I see it differently from you guys. Okay, like the instructor view, student view is a little different. Thank you so much. And I think someone always also wanted to know question 2. Go back over that one. Okay, so question number 2. A nurse is explaining electroconvulsive therapy to members of a depression support group, which statement would indicate an understanding. So again, when you have this type of question, you have just completed some type of an education, doesn't matter what the topic is. And you're going to get a statement from the audience. Is it a client or whoever you're doing the education to? When you get a question asking, is what is understanding or effective, you're basically saying the client made this statement about what I educated them on, and their statement is accurate, or their statement is effective, or teaching was effective. That means they understood what I taught. So the answer that I'm going to choose is the correct answer regarding the topic. All the other options are incorrect. Okay, I did my teaching. You made this statement. Your statement indicates you do not understand what it is that I taught. So I would need to go back and reinforce teaching, or just, see what it is that you're having the confusion about and correct that. Okay, so for this question, you're looking for the one statement that indicates the patient or the client, whoever made the statement, they understood your teaching. Okay, so the first answer was ECT treatments are given for severe depression when other meds have failed. ECT treatments are given as a one-time treatment to someone with depression. ECT treatments require shaving the hair at the temples prior to treatment. D, ECT treatments are safe. There are no major side effects or complications. So one of these statements is accurate. 3 of these statements are not accurate. So let's talk about the inaccurate statements first. Okay. B is incorrect. This is not a one-time therapy. Now, there was a question that we went over that talks about, I think it was the client's 6th or 7th time. You will do ECT as often as needed under the supervision of a mental health professional. Some clients will need more than one session. That is normal. Not everybody sees the effect right away after the first treatment. So again, why informed consent is so important, because we're going to explain this to you. If this is the route you're going to go, you need to be committed to it, because you may need more than one session. Okay. C is incorrect because you do not have to shave the hair at the temples. The probes, you can put the probes through the hair. You do not have to shave. Okay. Um, I think this kind of gives the impression of like an AED, a defibrillator. It's not the same concept. It's two different things. So you do not need to shave to do at the temples, at least. Because again, I mean, at your temples right here, there's really no hair there. Okay. Yes, hair can't interfere with electrical, conduction. Yes. But in this case, you do not need to shave anything at the temples when you place the probes on those sides. Okay. And then D, we already established treatment is not 100% safe. There are major side effects, loss of memory, confusion. Okay. Is this permanent? We do not know. Every client is different. Some recover memory loss and confusion right away. For some, it's more long term. And for some, it can be permanent. So it's important that clients know this, because if they choose this route for therapy, they can experience lasting side effects. Okay, so the correct answer was A. Okay, ECT is typically used. You're welcome. Sorry. ECT is typically used when conventional treatments like medication and therapy just does not work. And again, we do not come to this decision to do ECT lightly because of the risk. We want to make sure we can, safely say nothing else has worked for this client. We have done everything. We have adjusted. We have did this. We have did that. The client is simply not improving, or their condition seems to be getting worse. So because nothing is working, we've tried everything we can possibly try, then we would possibly go the ECT route. after explaining to the client or a family member if the client, is not able to speak or comprehend for themselves.
Thank you so much, Prof.
You're
Good
so
night.
welcome, Miss
Happy
Shell. You're so
Easter.
welcome.
Bye-bye.
Anybody else have any questions? These are good questions. I love it when you guys, talk about stuff. I love it.
I have a question.
Yes.
So I was taught about thought stopping. So would that also be with bipolar and depression?
So, for anybody who are not sure what that is, could you explain what that is?
So it's like a rubber band, or yeah, I believe it's a rubber band, and you just snap it if you have the thought of like
Mhm.
impulsiveness. And I'm trying to think which disorder was part of that thought stopping
Could
process.
be OCD.
Okay.
Now, here's the thing about that. So that is more conditioning, okay? And again, you can use a variety of treatment when you're managing mental health disorders. So that's almost like conditioning, okay? You are conditioning your body to do less and less of those behaviors or less and less of those thoughts. You kind of associating a painful stimulus with the thought. And in order for that to be effective, the client has to have the awareness and they have to actually participate and do it. Whenever you have this negative thought, you're supposed to, like you said, pull the rubber band and the rubber band snaps. And it's supposed to be an unpleasant feeling. So you are conditioning your body to feel something unpleasant whenever you have this negative thought. After a while, you're not even going to need the rubber band. Okay, you are going to just have that conditioning. A perfect example of something like that is Pavlov's dog. If anybody ever heard of that experiment. So there was a scientist with a dog, and what he did was whenever he was about to feed the dog, he would ring a bell. Okay, so when the dog heard the bell, the dog knew it was time to eat. And what started happening is the dog was salivate when he saw his food. Okay, so you had three things going on: bell ringing, dog salivating, food. So after a while, what the scientist did, he took away the food. Okay. Because at first, that was the only way to make the dog salivate. He saw food. So what happened was eventually the dog became conditioned to the bell. So whenever the scientist would ring the bell, the dog would start salivating without even seeing any food because the dog's body and mind had been conditioned. When I hear this bell, I'm going to get something to eat. Without even seeing it, the dog is anticipating it. So with the thought stopping, it's the same concept with the rubber band and the bell. Okay. But it's kind of, the roles are kind of reverse how it happens. You already have the negative thoughts in your head. You're just trying to change your thought processes. So whenever you start to have those negative thoughts, you snap the rubber band, it's supposed to give you a painful stimulus. Okay. After a while, the body will be conditioned that if I have this thought, I'm going to feel pain. Even if you do not flick or pull the rubber band, your body is going to perceive pain. So the goal is to, over time, get you to stop having those negative thoughts and feelings because you do not want to have a painful stimulus response. Okay. So, yes, you can definitely use thought stopping in that manner. You absolutely can.
Yeah, the reason why I asked is because we never were taught about bipolar, as
Mm.
ECT was an option as well. Um,
Yes.
only
Yes,
order.
you absolutely can. Now, here's the thing. Remember we talked about CBT, okay? Cognitive behavior therapy. Thought stopping falls under that category. So when you say CBT, that is a very broad type of, cognitive therapy. So CBT is a bunch of different types of therapies under one umbrella. Thought stopping does fall under that umbrella. So if you're saying you're going to use CBT to manage a mental health disorder, thought stopping falls under that umbrella. You can use thought stopping as a form of CBT. So yes, you absolutely can. You guys are welcome. You are very welcomed. Does anyone else have any questions? Any other questions? These are great questions. Okay, make sure you guys click on a link. You're welcome. Make sure you click on that link to leave your reviews. They are very, very helpful. Okay, and if we are done with the questions, then we are free to go. Again, I am doing another webinar. I think my days are going to stick Sunday, Wednesday, unless something comes up. So you guys can go ahead and look ahead into the tutor schedule. And I hope to see you guys again, either Wednesday or next Sunday. So you guys are free to go. Have a great night and have a good day tomorrow.